Hello, everybody. I'm Luigi Di Biase from the Albert Einstein College of Medicine at the Montefiore Health System here in New York. And I'm privileged today to have with us Professor Jeremy Ruskin. I feel that, he's a pioneer in the field of electrophysiology. And I feel really privileged here to have him interviewed today. The reason of this interview, Jeremy, is to celebrate the 30th anniversary of the AFib Symposium. So, first of all, I have to say congratulations. And this is something extremely important as an achievement. You have received awards all over the place. You have a career that is second to none, but 30 years of a conference on a disease that you had really the idea 30 years ago to say, this is what going to be my baby for the next 30 years. Were you expecting that?
Well, first of all, Luigi, it's a pleasure to be here and thank you very much for your kind words. No, I don't think any of this was really expected. The origin of this in 1995, when we put on the first meeting, it was actually David Keene and myself, um, was based on the fact that it was evident that there was a major public health issue that was looming and wasn't evident to most people at the time, and that is this tsunami of AFib that was coming at us based on both demographics, aging of the population, and the epidemics of obesity and cardiometabolic disease. And at the time, you probably remember, most electrophysiologists in the 90s had no interest in atrial fibrillation. There was nothing that we could really do about it other than anticoagulate patients and use some medications where possible. And most of the patients were taken care of by primary care physicians and internists. But it became clear, at least to me, that this was a problem that was going to become ours very quickly, and that we needed to begin to grapple with it. And that was the origin, really, of the first meeting in 1995. I will say that there were a couple of very brave individuals, including John Schwartz, who was doing attempts at linear ablations in the left atrium at that time. And obviously, these were very primitive procedures, very high complication rates, commonly lasting 12 hours. And nobody at the time thought this was the solution, but it was clear that it was the beginning. And it was obvious that this was going to evolve, or at least we hoped it would evolve. And so those were really the roots of the first meeting in 1995. I will tell you that my thought at the time was maybe we'll have 5 years of interesting meetings to follow, and then there won't be much to talk about, and we'll all need something else to do. So that certainly was way off. And to answer your question directly, yes, 30 years is a surprise. And look at where we are now in terms of how exciting the field has become. But to me, it certainly doesn't feel like 30 years. It's gone in a breeze.
Thank you. I mean, what I have to say is that I can't hide my emotion here because, I signed up to medical school in 1994 and graduated in 2000. So you celebrating the 30 years here, but I feel like I'm celebrating too because, I witnessed this conference as a student. It was my dream in Italy to go to the AFib Symposium in the year 2000. And over the years, I start, participating to your meeting from 2006. And then from 2012, I had the privilege to be part as a faculty. So I kind of, you are the founder of this meeting. I have been following this meeting. So I feel like real emotion here being able to call you Jeremy, where for me, when I was a student in Italy, you were, kind of a myth over there. So I really feel some sentiment here that I wanted to express and to share with you. But if I had to say something, so Jeremy, 30 years, you start where we had to anticoagulate the patient, but you have seen it all. You have seen the linear ablation, the first PVI, technology, RF, more RF, cryo. Today we have PFA. Can you, from your perspective, what do you feel are the 3, 4 pillars of the evolution in the management of this arrhythmia? Not to forget, of course, the thromboembolic and stroke prevention component of it.
Yeah, a lot of exciting key sort of developments. But let me first thank you for your kind words and also emphasize to everybody who's watching what a critical part of the meeting you've become. So it's been a great pleasure for me, one, to watch you evolve in your career and to call you a personal friend. So thank you as well. In terms of the key developments, I think that I would list them as follows, and this is not in any particular priority or order of importance, but certainly the work that Michel Hazaguer and Pierre Geyse did with defining the veins as a critical source in at least most forms or many forms of AF, and leading to the development or the evolution of pulmonary vein isolation was obviously a huge step. And there were a number of years at the meeting where that was the primary focus. What's the optimal approach? What are the risks? How to manage them? What are the best types of catheters to use, et cetera. So that was a huge advance and really kind of placed the field on a very different footing. I would say that the development of the direct oral anticoagulants was a sort of earth-shattering development in the sense that although we'd all lived and worked with warfarin for decades, and the drug had obviously saved countless lives, as you know, it's a very difficult drug for patients and a very difficult drug for physicians to work with. The younger folks coming along now have no sense of that. I mean, they may use warfarin in somebody with a mechanical valve, but the idea that you had to struggle to keep somebody safely anticoagulated with PAF, is something that's foreign to young trainees now. So that changed the field in a very dramatic way, and I think it's impossible to overestimate the importance of that. I think appendage closure, which followed, was also a kind of game changer in terms of changing the field of stroke prevention in a way that opened up possibilities that nobody'd ever thought about before. And as you remember, the evolution of appendage closure was a slow one in the sense that there was a very long regulatory hiatus. Understandably so, because FDA was looking at something that was entirely new and different, and access to the device was quite limited except for participation in clinical trials for a very long time. But once that period passed and the data clearly established not only the effectiveness of the device, but its safety and its impact on hard outcomes, we're living in a very different world, and you have witnessed the dissemination of appendage closure technologies to broader and broader numbers of patients, to the point now where the discussion is it on a par with DOACs, at least for some subsets of patients? And do we really have a choice now between a mechanical approach to stroke prevention versus a drug in a large swath of patients with AF? That's kind of where we are in 2025. So that's been quite dramatic. I would say also, obviously, that the advent of pulsed field ablation has been a game changer. Um, Still, obviously, a lot of discussion going on and a lot of learning still happening with that technology. But for a technology that's been around for 50 years and is now being finally tamed and used safely and effectively for AF ablation, it's a pretty amazing thing to watch and witness. And I'm sure you see this at your institution. It's changed the speed and efficiency of the procedure in an almost unrecognizable way, and has also enhanced safety. Um, Whether the effectiveness is any different from thermal ablation, I think is debatable, but we're dealing with rates now that are quite respectable in terms of effectiveness, and on a much better footing in terms of safety, and with an ability to service more patients per day than one ever would have imagined possible. Who thought AF ablation was going to become an outpatient procedure, which is where we are now. So I would say those are sort of the top uh, really sort of dramatic changes that we've witnessed over the last several decades. And I would begin to put the SGLT2 inhibitors and the GLP-1 agonists probably in that pantheon, because it's early days yet, we still have a lot to learn. But from what we're seeing with all of the trial data, uh, these classes of agents, are clearly changing cardiology. And I think the impact is trickling down to AF as well as other hard endpoints in patients with cardiovascular risks and cardiovascular disease. So I think if you asked me the same question a couple of years from now, those two classes of drugs would probably be on the list as well.
On the list. But again, we are celebrating 30 years of your conference. And let me dig a little bit more into it. Like, I feel like something that needs to be highlighted is the unique format. Before, in a very humble way, you said, well, I thought it was a 5 years conference. It became a 30-year conference. You have pioneered a lot of things. You have pioneered education. You have pioneered the creation of arrhythmia section and arrhythmia unit in your career. But this conference is unique too, because ahead of society meeting, you created a specific atrial fibrillation symposium where everybody goes there. And in a single room, the whole scenario of the disease is basically restudied. You start from basic science to anticoagulation to management, medication, ablation, and now left atrial appendage enclosure and technology. Why this idea came from, I need to do something where people sit down, focus on one thing. They don't go to several rooms. They don't go to different speakers. They can sit in one room. How this idea came, how you came out with this.
Well, you really put your finger on the essence of the meeting, I think. I think if the meeting has real value, it is because of what you just articulated, and that is that we can get a sizable group of people with a common interest together in one room to share knowledge, questions, discussion, debate, argument, etc., about a topic that we're all very interested in, which is AF and remains limited to AF. The thing that surprised me about it, which I referred to earlier, was that instead of needing to look for topics or ideas, we're in a situation now where there is so much to talk about, so much to grapple with, so much to learn, that even with a 3-day meeting, we end up cutting 20-30% of what we come up with in terms of ideas. And that's a wonderful problem to have. It means that there's a lot of excitement and a lot of advances in the field that create the fuel for these kinds of conversations. But as a meeting organizer, there's also an element of frustration to it, because I wish we had time for much more basic science. I wish we had much more time for just talking about the kinds of individual cases that we all struggle with in terms of patient management. But at the end of the day, the goal is the same as it was at the beginning, which is to get a group of people who are interested in the problem in one room, in a collegial way, who can enjoy each other's company, focus on a host of challenging intellectual problems, and do it together collaboratively in one place. And I was very heavily influenced by my experience at big national meetings, which have a critical place. I mean, we need large society meetings for obvious reasons. But my challenge at those meetings in terms of the scientific content was I felt scattered all the time. I would run from one room to another. I'd get a piece of this and a little piece of that. And at the end of the day, clearly I learned a lot at these meetings, but I never kind of felt that I got everything I wanted to get or needed to get. There was always a level of frustration about that. And so the design of this meeting, which was not in any way designed to compete with anyone, it really, as you said, it had a single topic in a single room. And that was really all we wanted to do. And I think if there's one thing we've done successfully, it is to be able to continue that. We've all often had the sort of impetus and at times even pressure to have multiple simultaneous sessions. And we've, I think, to the credit of the meeting, we've resisted that. Its format remains the same, which is if you're interested, all you have to do is show up, put your backside in the chair and hang in there for 10, 12 hours. And whatever we've got to offer, you'll get in that room. There's nothing else to distract you. So we hope to continue that. I would also add, and again, I apologize for such a long-winded answer, but one of the other great features of the meeting for me has been the continuity of the people working on it. We have a small group of people. Musa Mansour and I now, we work all year on this. I mean, the meeting will be over at the end of next week or the beginning of the following week. And we'll probably take a breather for a week or 10 days, and then we're back at it. So there's a lot of hidden effort here that goes into this. And I think there are very few people who are crazy enough to put as much time as we do into the meeting. And the rest of the team, Muriel Corcoran, Rob Matthews, Genevieve Finnegan, Ellen Corcoran, these are people who've been working on the meeting for decades. So we have a history together and we have a sort of institutional memory and have learned, by our mistakes, what not to do and what tends to work. And we continue to learn every year. And that piece of it, working with people you like, people who are all pulling in the same direction, has been an enormously valuable thing for me personally and professionally.
You have preceded my next question, which was, I feel history is very important and looking at the past is very important. And so my question was, who are the people that you feel you want to remember or mention that have supported you over the years to make this meeting successful? Because there's nothing you can do by yourself. You need people around you. People have changed probably over time, although some of them remain very consistent and constant with you. You mentioned basically all of them. I don't know if there is anybody else that you want to mention. It's very important for me to learn from the past. There is no present if we forget the past. Nothing, come out of the blue. There is people behind the scene that are working on this.
Yeah, it's such an important point, Luigi, and I couldn't agree with you more that history is a critically important factor in all our lives, not just for this meeting, but I think, as electrophysiologists, there's so much wonderfully interesting and important and rich history to learn. And I sometimes feel bad that our fellows don't get a greater exposure to that. But to your point, we all stand on other people's shoulders. And, I owe my whole career and a huge debt of gratitude to Tony D'Amato and also to Masood Akhtar, who were the two people who really mentored and taught me electrophysiology. In terms of the meeting, David Keene was there from the very beginning and has been a steadfast participant in organizing this. Vivek Reddy played a huge role for years when he was at MGH and has continued to play a very important role in all aspects of the meeting since he left and went to Mount Sinai. Musa Mansour, I've mentioned, obviously continues to work closely with me, and it has been in the last decade an absolutely critical part of the meeting. It just literally would not exist without Musa's input and effort and expertise and skill on many fronts. And Pierre has been a contributor also as one of the organizers over the years. And then the other thing I want to mention is the faculty. I mean, the faculty, and it does evolve. We try to get younger people onto the faculty every year. But this meeting is about the faculty and the people who come to attend. That's really where all of the chemistry and all of the sort of substance of the meeting take place. And the faculty has been, and in particular, people like you and many others, very loyal, very committed, very enthusiastic. And without that, there's no meeting. So, I can't express deeply enough my gratitude and appreciation for the incredible faculty that we've been able to get together every year. These are among the most talented people in the field, and their contributions and their enthusiasm is really what makes all of this a valuable experience.
Thank you very much for the nice word. It's very, very, inspiring to hear from you that, you still are able to honor your mentor. I think this honoring the mentors, it's something that, the new generation should never forget. And it's something I'm very, very deeply careful to, you are good. Each of us can be good, very good, extremely good, but we still are somebody because we received something from a mentor. And I think we should never forget that. And, at basically your stage of career, you're still honoring your mentor. It's something that really is inspiring. We're reaching out to the conclusion. In the last years, the last question I have is like, the meeting has been implemented with live cases. And what do you think is one of the most important or interesting feature of the live cases in your opinion?
It's a good question. I think that there's a great attraction. The audience really seems to enjoy and appreciate real-time experience, watching operators do their cases and at the same time, at times have to struggle with difficult questions and decisions that all operators experience in the laboratory. So there's an element to it, I think, that allows people to identify, appreciate, and also learn in real time how some of the best people in the world grapple with the same issues they face every day. It's always a bit of a, it's a bit of a nail biter in the sense that we understand that there's no guarantee that things are going to go the way you want them to go. And I think that element also appeals to people. I will say that one of the things that we emphasize to all the operators and faculty is that when you're doing a real-time case, we have a number of rules. One is you have somebody next to you who can do the talking, because your job is what it always is, which is to take care of the patient. And the first 10 priorities are patient safety. So we want people to focus on that, and we want the audience to see that happening. And for that reason, we always have someone, a colleague in the room with a mic who can do the talking and the interacting while the operator is doing what he or she is there to do. As you know, we also have recorded cases. They tend to be a bit more scripted, but they have a purpose as well because they're sort of designed as a didactic teaching tool, and the two sort of complement each other. And this year, there are a lot of cases. We have a really almost full session of appendage closure cases on Thursday, and then a sizable number. I think the total is about 20 cases altogether this year. So that will be a very significant part of the meeting.
Thank you. So all I can say again, I congratulate you, all the organizer with you about the meeting that is behind the corner. Is going to be soon to happen. Is the 30th anniversary, an historical celebration. And the way I look at atrial fibrillation management, probably there will be another 30 years for this meeting because, as you said before, there are still things that we have to exclude. There is no time, and keep evolving and evolving. So first of all, congratulations. Second, anything you would like to say to the audience about what's going to happen next week?
I just want to say thank you, Luigi. It's been a pleasure. Thank you for helping us mark this important milestone. The meeting is online. You can see the program. It's a very dense, exciting program. And I hope that lots of people come and enjoy it and that it goes smoothly. Thank you again. I really appreciate the opportunity to celebrate this and talk about it with you.
Thank you very much, Jeremy, for your time and your friendship. And again, congratulations to the 30th anniversary of the Boston Atrial Fibrillation Symposium. Thank you very much.